Moving on to our next category.
Good evening, everyone. My name is Noah Johnson. I am an undergrad here at University of Arizona. I'm a sophomore studying biology with a minor in anthropology. And we got connected with the Sonoran Center with our work with Dr. Julie Arman, JC Farkas.
Hi everyone, my name is Beatriz Blandon Orozco. I'm with the University of Arizona and I'm doing major in molecular and cellular biology with minor in special education and EMS.
So we are very excited to be here to speak with you guys about our project. Like you said, it's led by Dr. Julie Arman and JC Farkas, and it focuses on building a navigation model for community health workers to help refugees with disabilities better understand and access their resources, not only within the healthcare system, but also outside of it. Me and Beatrice played a small, but we'd like to think very crucial role in this project. But before we get into that, we want to get into some background information to help you guys better understand. For those of you who don't know who a refugee is or who might be considered a refugee is someone fleeing their country because they are in fear of being persecuted for their religious beliefs, political opinions, nationality, race, or maybe association with a certain social group, and they flee their countries and seek refuge or asylum within countries like the US. So when they come to countries like ours, oftentimes they're supported, but they lack knowledge or they face barriers to the social determinants of health. I would hope that most of us know about the social determinants of health, but yeah, they face barriers such as language barriers, inefficient access to quality foods, education, transportation, and most importantly, healthcare. And on top of that, 20% of refugees have disabilities, according to our research. And so, on top of all these barriers, they now have another wall to overcome and now need to find treatment, assistance, care, or technologies to help them live their lives efficiently, whether they are an individual with disabilities or have a family member with disabilities. So luckily, Pima County isn't lacking or limited in these resources, but these refugees are limited in their knowledge and access to these resources. So that's what our project hopes to fix. So Dr. Arman had us to do 3 assignments, one of which was to conduct an analysis of community health worker models that are currently working with immigrants and refugees, and analyze them to look at benefits and maybe things that we could also change. And then we also did a policy review looking at current policies and how they're affecting refugees' eligibility for certain services and criteria, and not only looking at how their criteria is right now, but how it might change in the future. Because we know with this political environment right now, everything is changing. So it's good to know what might happen in the future. And then finally, our biggest project that Dr. Arman had us do was an environmental scan of Pima County, looking for beneficial resources for refugees with disabilities. We split these resources up into 2 categories, ones that were specifically focused on refugees and doing hands-on work with them, and then more community-based resources such as food security and housing resources. And then we also added disability resources, whether that be sensory or motor or intellectual. And we put all these resources into a spreadsheet. It is on this QR code. Unfortunately, this QR code stopped working a few days ago, but luckily we made a map that also has our resources and all the information, which is on the left if you guys want to scan that. And I'd like to say we are also not fully done with this project yet. We are still adding resources to this and continuing our policy review, but that's not to say that we haven't learned anything through this process. And Beatrice will take us through what we've learned.
Okay, so through all these assignments that we did, we find a few key findings. One of them, one of them was these all these refugees were having trouble finding the access of these resources, such as housing, maybe like food resources or the transportation as well. And that can be due because of language barrier, especially, and because these people are trying to manage a new life in a different environment. So that's a little bit complex for them. We also find a lack of advertisement and access to all these programs. So, for example, if people, refugees in this case, need to access to like a specific resources, there's just not a lot of information, especially because not a lot of people know about this. So we found that the access of these programs is a little bit limited because of that. We also have a lack of the eligibility criteria process. It's a little bit hard for them because they're focusing or in trying to like find jobs and like find a stable job for their families, and trying to manage all that with the with adapting to this new country, and they came here to the US. So that makes the eligibility process really harsh to navigate. With that, I wanna introduce the HR1 policy that makes even more complex for the eligibility process. Because the HR1 that was established last year, for July of last year, it made make like the Medicaid and it's not really hard to apply for that. The eligibility is crazy right now. So with that, I want to introduce the CHW models, which is going to be a sustainable framework for these, because these CHWs are specifically are built in trust, so they can be really like help them to not begin through all these healthcare resources, because especially for them is really hard to see like healthcare resources. Maybe they have problems with time, they and because of that, like they need to have like some kind of help for them, and yeah, sorry. So these CHWs really help with that, with the DD navigators, and help overcome all these like problems that they are not navigating through. So with that, I want to conclude showing these flowchart that we made, like refugee arrives in the United States, unfamiliar with all the USA systems, and what we want to overcome is that the refugees will be connected and informed, and understands this eligibility process. And with that, we want to have improved outcomes. So with that, like, if you want to know more about this project, you can contact us, and you can contact also Dr. Armin and Dr. Jesse Vargas.
We have one trainee here in person and Dora, are you online?
Hi.
Dora's there. Guys.
Dora, do you want to introduce yourself?
Yeah. Hi, my name is Dora. I am a second year master's a public health student with a concentration in health service administration. and I am a part of this diversity fellowship.
Hi, everyone. I'm Srishti. I'm a junior majoring in bioinformatics and will also be at U of A for medical school. And I'm a diversity fellow as well.
And we're happy to present today about our work identifying components of a disability navigation program for refugees in Pima County. To give you some more background on why this project is so critical, refugees who arrive with disabilities navigate an intersecting set of vulnerabilities. Not only are they adjusting to a new country, but they also face profound barriers to accessing necessary healthcare and social services. These barriers extend past medical needs. They are heavily compounded by cultural, linguistic, and systematic challenges that drive significant health inequities. Despite this, there are very few programs out there designed specifically to address disability navigation for refugee populations. Here in Arizona, accessing support means interacting with disability services like the Division of Developmental Disabilities, or DDD, and the Arizona Long-Term Care System, or ALTEX. These systems are notoriously complex to navigate, even for native English speakers familiar with U.S. healthcare. Now imagine trying to navigate them with a language barrier and a different cultural understanding of disability. That is the gap our project aims to bridge. Because this is an issue deeply rooted in the community, our design was built to be community engaged. We didn't do this alone. We partnered with the Sonoran Center of Excellence in Disabilities, Encircle Families, and the International Rescue Committee right here in Tucson. Our intervention focused on the front line, the refugee serving staff, organizations, and clients. Our plan was to conduct 4 separate training sessions covering the most critical hurdles, such as understanding eligibility for these disability service systems, managing the applications, gathering documentation, and effective advocacy. And to evaluate how well these training sessions worked, we used a retrospective post-test on a 1 to 4 scale. And we also integrated follow-up interviews into our design to see if this knowledge was actually retained and utilized in the field. We then analyzed this both using quantitative and qualitative methods.
Like Dora. Another one.
Like Dora mentioned, we basically gave caseworkers at the International Rescue Committee a survey, and that survey measured improvements on a scale of 1 to 4s, with 1 representing the least amount of knowledge and 4 representing high familiarity and comfort with subject at hand. And so we've delivered 2 trainings so far. The first one was delivered by AZDES, so Arizona Department of Economic Services. They're responsible for actually providing DDD and ALTEX benefits. And the second one was delivered by actually some folks at U of A and focused more on advocacy. The first one also included a training from Encircle Families, which is focused on teaching families how to navigate the process of disability and how to advocate for their child. And so there were 4 main categories we assessed understanding on: eligibility, application process, advocacy, and sort of general supports and overall improvements. And we did find significant improvements. Remember, this is on a 1 to 4 scale, and so even a 1-point improvement is pretty substantial. Across all 4 categories in both trainings. The first training had a few amount of people, but it was so popular that more caseworkers at the IRC, which is also where I work, decided to join. And overall, the largest knowledge gains were in understanding how these systems interact, like how does DDD and ALTEX interact, because both of them are for people with disabilities, and which one should my child or client be eligible for. Advocacy and troubleshooting, a big one was knowing who to contact and why. For example, if a claim was denied, how do I contact for support and advocacy and legal support in those situations? And then also, again, navigating specific contacts at DDD. So a lot of those aren't like explicitly listed on the website, and so actually having a contact on hand was super helpful for clients and caseworkers at the IRC. The main feedback we got was actually more time for the training because they found it really, really helpful. with also an emphasis on the role of interpreters. One of the things the IRC caseworkers emphasized was that there was often a difficulty in accessing interpreters, specifically for certain languages, especially in-person services. And so overall, we're seeing these substantial improvements, and this suggests that this training is actually effective. And one thing I do want to really emphasize here is this is a mutual learning framework. There's gaps in every step of the way, right? Knowing who to contact, how do I get support afterwards, but also gaps in understanding from DDD to people that actually have disabilities and what the lived experience of that is like. And so caseworkers were informing staff at, AZDES and DDD, here are the gaps we've seen. And then they were using that to improve their services. And so it was really interesting to see that in person. Imagine, I'm American, I speak English, and I was still frustrated and confused when I was trying to understand eligibility requirements for these services. And so imagine having to do that when you're not from this country and you don't speak English. And also some other qualitative barriers we realized, speaking to some of the caseworkers myself, is the difficulty in actually getting a diagnosis for your child if you're a refugee family, because a lot of providers will struggle to understand and differentiate between whether a child, especially if they have an intellectual disability, is behind in school because they don't speak English versus they have trauma versus they actually have an intellectual disability. And so actually identifying and obtaining a diagnosis is also a big barrier for these families. And so all of these, sort of effects result in a compounded disparity, especially for those with, children who face these disabilities that don't speak English as their first language. In the future, we actually also plan to interview directly families with children who have disabilities to inform our findings directly, because I'm sure there's gaps we haven't identified yet. And ultimately, all of this is being done to inform core competencies for someone that can actually help families navigate the, disability process in Arizona. So that would be a disability navigator, and that's what this project ultimately aims to do. But so far, we're seeing even these trainings have been so effective so far. If you have any questions or interested in learning more, you can stop by my poster or contact Dr. Arman at the email listed on the slide. Thank you.
Right. Hello, my name is Akansha Kanya. I'm a junior double majoring in nutrition and human performance, as well as rehabilitation studies and services, and I'm part of the undergraduate certificate program with the Sonoran Center. All right, so this is a project that I have been working on for the past year with Dr. Tamsin Bassford, and it's part of her larger research on supported decision-making in the Arizonan healthcare realm. Supported decision-making is a less restrictive alternative to guardianship, which allows individuals with intellectual disabilities to retain their decision-making authority. However, due to the relative infancy of this framework, physicians and providers aren't necessarily sure on how to even discuss or use supported decision-making with their patients. So the goal of this research was to assess physician knowledge, attitudes, and behaviors that hinder implementation of this program, as well as workforce barriers such as limited time with patients and how that affects implementation of this program overall. So my role in this research was to do a literature review on how previous implementation of this program has worked and what barriers they have identified themselves. And then we use that literature review to inform our survey that we will eventually send out to Arizonan physicians. This project is still ongoing, so we have created a survey and are working to distribute it to Arizonan physicians and providers. And then based off of what the results we get from that survey, we're going to use that to create educational materials to actually inform the gaps that the physicians themselves have identified, and better inform them on how to use supported decision-making with their patients. Some results that we have found in our literature review was that there wasn't a lot of literature out there about supported decision-making. Like I said, this framework is in its relative infancy, so we had to utilize resources both from the United States larger, but also outside of the United States. Something that we found that there is a similar framework already out there called shared decision-making that allows patients themselves to advocate for their care. And then we also then focused on how physicians actually feel when they work with individuals with intellectual disabilities to better inform how they would feel overall interacting or even using supported decision making. If you are interested in more research on more results that I found in my literature review, please come find me at my poster. And then if you are interested in further questions, please contact me at my email. Thank you.
Okay, hello everyone. My name is Nicholas.
Sorry. Jumped ahead. So our next presenters are a group. They also cannot be here today. So this is our last recording of presentations. We have a few more that are live.
Okay, hello everyone. My name is Nicholas Amjadi, and today we'll be presenting you our poster, Developing Accessible Cancer Clinical Trial Education Tools for People with Intellectual and Developmental Disabilities.
Hi everyone, my name is Susana Rivera.
And my name's Carly Smith, and people with intellectual and/or developmental disabilities are frequently excluded from cancer clinical trials, partially because the information about the trials, the consent process, and participation in the trial is not accessible to this population. And so this project lays the foundation for intervention to support patients with IDD and the clinical trial staff with a two-part goal, both developing plain language educational materials and identifying existing decision-making tools that can be adapted for this audience.
And moving on to our method section. So for our methods, we focused on developing materials that are accessible and understandable for people with intellectual and developmental disabilities. We worked closely with self-advocates, family members, and the University of Arizona Cancer Center to guide how these materials should be designed. And from this, we simplified our cancer clinical trial information by using plain language, shorter sentences, and supportive visuals. So essentially, the goal was to reduce the complexity of the cancer trial slides without losing its important meanings. And we prioritize clarity and structure within the slides to do that so the information is easier to follow. And we also reviewed existing decision-making tools to identify what already works well. And for example, this included looking for features like simple layouts, clear wording, and helpful visuals that support understanding. We then finally revised our educational materials based on feedback from our stakeholders. And this step was very, very important because it obviously ensured that the materials were not just theoretically accessible, but actually effective in helping people understand and make decisions about clinical trials. And moving forward with our results section, from this process, we developed accessible and educational materials and slides that explain cancer clinical trials using plain language and visual support. We also identified several important features that make decision-making tools more effective for this population, and these included things like clear structure, simple wording, imagery that's supportive, and a space for questions. And these elements consistently improved the understanding and engagement for all people reading through these slides. So overall, our results show that simplifying language and incorporating visual supports can significantly improve how clinical trial information is understood. And obviously, this not only helps people with intellectual and developmental disabilities, but can also make these materials more accessible to a much broader population.
So, as we kind of explained, the purpose behind this project was to to show that like improving understanding and participation of people with IDD in clinical research. And this overall supports a more equitable access to research and helps ensure that studies better represent all populations. And so, in the middle here, we have an example of how we made these materials more accessible to this population. So, the first slide shows the original materials about one of the slides about the clinical trial. And then we shortened it and added visuals to the original PowerPoint materials to make them easier to understand. But then after another round of review, we realized that there was still some wording and language that maybe was not accessible. So from there, we made all of our slides into plain language slides so that they could be read and understood by the largest number of people.
Yeah, and then figure two highlights some of the different existing helpful key elements that we identified. For example, the first large image shows a table of contents that clearly explains what the document is and how to navigate it. The first and third image are really good examples of simplified aids for determining preference. So like a checkbox of yes and no. And then the second and fourth image are examples of simplified imagery. If you'd like to see more of these key elements, we have a QR code on the bottom right of our poster that's available to view those elements. Now moving on to our discussion, our background research has highlighted that there exists some resources that can be used as guides for the development of other inclusive materials. While developing those materials, it's important to consider the important role the lived experiences and opinions of stakeholders play in the resource development process. Additionally, keeping in mind that making these materials more accessible is not only of benefit to the IDD population, but also to the general population is of the utmost importance. And then in regards to future plans, kind of like been mentioned earlier, continuing to adapt these materials based on stakeholder feedback is important for future development to ensure that materials can be accessed by the widest population possible. And then continuing to search for and identifying key elements and key figures that can be integrated to help make both the clinical trial process and support a decision-making process easier to navigate are imperative for that nuanced and well thought out development of accessible materials. Thank you.
Thank you, everyone.
Thank you.